class. So today we're going to start talking about different ways to categorize mental disorders, ways to conceptualize, if you will, what we're talking about again when we say abnormal psychology. So last time we really just described abnormal psychology, or more specifically, we described the definition of a mental disorder. And we walked through that just thinking about all of the different moving pieces that go into understanding what a mental disorder is, right? That it's not just as simple as thinking about, does the person have this or not? Can we find evidence of this in their body? Instead, we really have to think through, is this causing the person harm? Are they making a choice? Is this represent a way that they're different from ways that they've been in the past, right? We're considering all of these different moving pieces when we think about what a mental disorder is. And so that's where we started, just to get set up, is thinking about, again, that idea of what it is that we're talking about. As we move a little bit deeper into thinking about abnormal psychology, one of the things that I want to do to start us off with is to just think about ways in which we can begin to break down that idea of a mental disorder or an abnormal psychology, right? So we're going from this broader definition of what it is that we're talking about, and now beginning to kind of dissect what a mental disorder can be, the ways that they can look, and the ways that they can present themselves. So I'm going to give you several ways today to think about breaking down mental disorders. Some of these are ways that we still use today. Others of them are ways that maybe we have historically thought about breaking down abnormal psychologies, but we may not use them anymore. But some of these things I will just teach you because I think it's helpful to learn. Again, I think it's helpful for understanding and conceptualizing these various mental disorders, even if we kind of don't use that parlance anymore. And you'll see what I mean right off the bat here, actually, which is to say, the first thing I want to look at is what we call the five-axial model. Now, the five-axial model is something that, again, we don't really use this anymore. This kind of went away with the DSM-4. And in the DSM-5, we aren't given the same kind of boxes or the same criteria that were given in the DSM-4 in terms of how we're supposed to diagnose a client. And that's what the five-axial model does, is it tries to set up a full diagnosis, a full psychological write-up in a shorthand, brief way, but it tries to understand a lot of what's going on for a particular client by having us flesh out these five axes. And so, as is noted, right, this five-axial model is mostly found in the DSM-4, but like I said, I really like teaching this to you because I think it begins to help us understand different ways in which mental disorders can be sort of dissected or split up. But also, this is going to help us understand those other features, a couple other features that might be important to understanding a particular client's, mental disorder or presenting problem or whatever it is that they're showing up with. So, on the five-axial model, we're going to have five axes. This basically just means 5 lines of text that we're going to use to help diagnose or understand the diagnosis of this individual. And so these are just called axis 1, axis 2, axis 3, axis 4, axis 5, the five-axial model. And these first 2 axes are going to be the most important for the mental diagnosis. You'll see me write DX throughout the semester. DX tends to mean diagnosis. You'll also see me use it for disorder. So diagnosis or disorder. You may also see me sometimes write SX, which means symptom, and then of course RX, which means prescription. You'll see me write this less often, as psychologists don't prescribe, but you will see me use symptom and diagnoses from time to time. So these first two axes are going to deal with that DX, with that diagnoses. And then these second two axes are really going to have to do more with what you might call accompanying problems. And you'll see what I mean here in a minute. And then axis 5 is its own thing, and we'll get to that as well. So what are the different ways in which we might split up a mental disorder? This is usually a moment in the class where I would let you kind of wrestle with that, but you're not here. So I'll go ahead and tell you the ways that axis 1 and axis 2 are thinking about disorders differently, or why you might choose to put a disorder on axis 1 versus on axis 2. Well, first I should say, when we used this model, certain disorders almost always went on axis 1, and then certain disorders almost always went on axis 2. There are a few times or particular clients or particular clinicians who might prefer to put one diagnosis on the other axis. You're going to get that. People are going to do what they want sometimes. But in general, there were certain disorders that would go on axis 1, and then there were certain other disorders that would go onto axis 2. All of these disorders are in the DSM-4 and in the DSM-5, or some version or some changed version of them. You would find the DSM-5 as well. So what's the difference between these two? Well, in an axis 1 disorder, axis 1 is really used for most disorders. What does that mean? Well, in the case of this five-axial model, one of the things they were trying to distinguish that I would say that we've since learned is a lot more difficult to sort of tease apart than what the axis could do, which is one reason we probably got away from it. But what it was trying to do on these first two axes was distinguish between a pretty short-lived, a relatively short-lived diagnosis, a relatively short-lived disorder. That is to say, something the clinician or even of your own accord that you could expect to be healed of, if you like. We don't usually like using that word in psychology, healed or cured, but it's something that we thought could go away. That is something like depression, right? If you get depressed, we understand that that's not how you usually are. And one of the reasons that you might come to therapy, one of the reasons you might seek some type of medical help from a doctor or psychiatrist is because you want that to go away, and you have the expectation that this is not how I usually feel, and that's gonna go away at some point. I need some help to get there. So that's gonna be things like depression, that's gonna be things like anxiety, that's gonna be things like insomnia, that's gonna be things like eating disorders even, right? So all of these things that we would expect that a person could go into, that a person could catch, if you will, or experience at some point in their life, but later in their life we would expect within a few weeks, a few months, maybe even a few years, that person could get past it, that person could get through it and go back to being the person that they were, or at least find some peace or find some happiness within having dealt with that disorder. I don't know if I said that right, but you get what I mean. Here's my pen. So that's what we're looking at when we're talking about axis 1. So most things would go on axis 1, right? Because we would have this understanding that most things are relatively temporary. But again, that does start to break down, and I don't want to confuse you too much just yet. So let me first talk about axis 2, and then we'll come back around and think about some things that are maybe a little more difficult to pull apart or figure out where they would go. So again, most things go on axis 1 that you're going to think of, depression, anxiety type things. What we're looking at on axis 2 again, thinking about the difference between 1 and 2, thinking about that idea of a short-lived temporary disorder that I could cure you of, or that I could help you get rid of. What we're looking at on axis 2, of course, is the opposite. That is to say, disorders that we expect the person isn't really going to be able to get past, or the person was born this way, or the person that the thing that we're calling a disorder really just is their personality. That's just how they are, and we can't cure somebody of their personality, right? Like it's not depression, it's not anxiety. If it's something like narcissism, that's not something that is a problem in terms of at some point you weren't narcissistic and then suddenly you got narcissistic and that made you feel bad or distressed and you want to get rid of it, right? That's not how narcissism works. You have narcissism for most of your life. If you figure out that you have narcissism, you probably take a narcissistic stance on that. Hey, cool, I got a narcissist. Narcissists must be really awesome people. I'm an awesome person, so it makes sense that, you're gonna sort of fold it into that. That is to say, the things that are gonna go on to Axis 2 are really endemic. That is to say, they are who the person is, or they're at least expected to have the disorder or have the diagnosis in such a way that it really can't be taken from them. It really can't be cured. It is just something that the person really is. It is the best way to think of it. Not even that they can't be cured of it, but it just is who the person is. And it would be almost impossible without totally changing this person to get rid of that thing. Well, what am I talking about? Of course, I'm talking about things like personality disorders, as I just mentioned, right? And when we get to that section, one of my favorite parts of the class, by the way, when we get to that section, one of the things that you'll see, that you'll learn, is that these personality disorders are just the personalities. They are disordered personalities, named that for that reason, that it is who the person is. And so it's not something that you can just cure without really, really, really significant changes to that person as an individual. And generally we find that even then it's still relatively impossible almost to get rid of a personality disorder. So what other things would go on Axis 2? These are also going to include things like intellectual or developmental disabilities. So autism, Down syndrome, those types of things. Again, the type of thing that really is who the person is, right? That when you think about somebody who's on the autistic spectrum, some of those deficiencies, some of those, in some cases, some of those almost kind of special powers that they have, those sort of heightened abilities that they may have, all of that is really who they are, right? It's not something that you could go in and cure somebody of autism and then on the other side of that have a person that you recognize as the same person, right? Not to say that they, that they wouldn't be a recognizable person, but it wouldn't be the same person, right? You would understand that they had made a significant change in who they were. Same thing with Down syndrome, right? If you could cure somebody of Down syndrome, you would do so at the expense of who that person had been all their life. That's different than depression, right? Where you are depressed for a while, but you come back to yourself is how the person feels. It doesn't feel like they've gone away from themselves, right? That they were the depression, and if you take the depression away, they're going to be somebody totally else. So that's this difference, right? That these are going to be relatively short term, and then these are going to be relatively long term, or you might say rooted. I was going to try to spell endemic. I don't know. That's why I didn't write it. So basically, it's who the person is, right? It is them versus this is something they get. Now, part of the reason that we've gone away from this is that there are some things that are a little bit confusing in terms of where you would put them, or maybe they end up in a place that seems like it maybe should go in the other place. So some examples of these are things like schizophrenia. Schizophrenia goes on Axis 1. Well, why? Well, you do kind of get it later in life. It's not something you're born with. Not that we necessarily have stated that born with is happens down here, but as we mentioned, things like autism and Down syndrome, it kind of seems that way. Personality disorders are still a bit of a mystery to us in that regard, but certainly you get them very early, or you develop them very early in life. And so this idea of it being rooted or long-term does sort of make sense here, right? This idea of schizophrenia as being something that is incurable in most cases, that the person has to deal with for the rest of their life. In most cases, makes it seem like it's an axis 2 disorder, but you would have found that it is diagnosed on axis 1, right? That it is supposed to go on axis 1 as one of those more short-term, temporary, curable disorders. And again, in the case of schizophrenia, in some cases, schizophrenia does just go away. When we get to psychotic or psychoses, psychotic disorders or psychoses, we'll talk about what the difference is in which cases it seems like it can go away, be cured, so to speak, and in which cases we would expect it to stick around for the duration of the person's life. Either way, most cases, like I said, stick around, and so you'd think here's an axis 2 disorder, but again, in fact, it is an axis 1 disorder. Another one of these would be something like ADHD. Again, which you might consider an intellectual disability, close to something like autism, close to something like Down syndrome, just in terms of its neurological makeup and the fact that these people, folks with ADHD, seem to just come packaged that way, right? That it's not something that they get and it goes away, that it maybe at the very least is something that they're kind of born with and maybe grow out of, but generally it's something that is who the person is, even if it's just who they are in childhood. And so again, we might think, okay, well, this is a long-term disorder. This is something that is part of who that person is. This isn't something that we would necessarily be able to cure. The person may grow out of it themselves. So sounds like axis 2, right? Well, of course not. It is axis 1. Again, some of these things may come from maybe disagreement about where and how the disorder develops, or some new understanding of how the disorder develops. I think all of that's the case for schizophrenia, right? We maybe have thought for a while that we could cure schizophrenia, but common knowledge today is that it is, in most cases, something that somebody's going to have to manage for most of their life. I would say that's probably pretty similar to what's going on with ADHD, is that we thought so much that it was a childhood disorder and that most adults grew out of it, that we're only within the last 10, 20 years coming to understand that many adults also have ADHD and that it may present differently, but those parts of that person are still there, right? So shifts a little bit more from that long-term, even if developmental, into this more, from short-term into this more long-term diagnosis when we start to learn more about it. Other things that might go up here are learning disabilities broadly. So dyslexia, dysgraphia, those types of things, dyscalculia, all of those types of things we would consider learning disabilities. A person has difficulty writing or reading or understanding spatial instructions, whatever that is. We tend again to consider that an axis 1 disorder when, if you really think about dyslexia similar to ADHD, it really does seem to be that this person has a different neurology, which suggests that it's going to be something they're going to carry with them for most of their life, if not their entire life. So again, here's that difference. And I'm not super caught up on having you know where each disorder lies, right? But in the future, you probably will be doing papers. You certainly will be doing papers. And then maybe even your final will use some of this information in terms of the axes. And I do want you to at least know whichever disorder you choose for the paper or whichever disorder you choose for the final. I do want you to understand your own disorder and how it fits into that. So you don't have to learn everything about axis 1 and 2, but if you choose, I don't know, PTSD, figure out where that goes. So that when you're talking about it, or if I ask you to place it on one of these axes, you know where it goes. Again, not everything, but whatever it is that you're going to work through. Okay, so axes 3 and 4 are pretty different here. Axes 3 and 4 are really to help the psychologist understand different components of the individual client's life, such that we can maybe get a bit of a sense of what's going on for them just from reading this diagnostic sheet. This by no means is going to give us everything, but it might be able to highlight some really critical pieces that would save the client some time in terms of being transferred to somebody else, or having their paperwork sent to a hospital or something like that. And of course, is going to save the clinician some time in terms of having to re-ask those questions or connect some vague dots that might not otherwise be there. So what goes on axis 3? Well, on axis 3, we're going to get relevant medical conditions. So on axis 3, we're going to get relevant medical conditions. What do I mean by relevant? Well, I'm not going to put on axis 3 if my client shows up and they happen to have a cold one day, or even on the intake, the first time I see them, they happen to have a cold, and I just notice they're sneezing and coughing and sore throat or something. I probably don't want them in my office, but you know, I wouldn't necessarily write that down, right? I'm not going to necessarily just say, hey, you know, I'm just going to write down here on these axis 3 that the client had a cold. I could, you know, it's not, there's nothing wrong with it, but it's not really relevant, right? It's not really relevant to our work together, unless it is, right? And so I want you to understand, first of all, that this isn't a case, well, this isn't a diagnosis or disease by disease criteria. It really is a case-by-case criteria where, let's say that the person does have a cold, and generally if we're just coming in and they're talking about, I don't know, their marriage, and you know, they just happen to have a cold that week, so be it. You know, maybe some tissues, hand sanitize. But if they came in and they said, you know, listen, I had this really important job interview today, and look at me, I'm a mess. My nose is running, my eyes are watering, I couldn't get through a sentence without coughing, you know, into my hand or whatever, right? And they're sort of really broken up, and it's connected to the fact that they caught this cold on the day that they were supposed to have this really important interview, and now they're anxious about the result or depressed that they found out they didn't get it or whatever it is. That would be a time when I might indicate that, right? That I might indicate that the person had this sickness that affected them here in terms of their anxiety. What I'm trying to do is paint this picture, right? A more likely example would be something like I don't know, you get an athlete who's about to try out for the college team, and this is something he's wanted all of his life. He's worked really hard in high school, and he didn't get any type of scholarship, but they've invited him to a walk-on tryout, and he's really excited about this to show them what they got, right? To show him what he's got. Well, that weekend he's out partying with his buddies, celebrating the fact that he got invited to this tryout, and he busts his knee, right? He tears his ACL jumping off a staircase onto a table. What is that about? Anyway, so you see kids do this sometimes, or at parties, etc. And so he tears his ACL being an idiot, and of course, lo and behold, he can't make it to the tryouts that next weekend. So in that case, right, and now he's depressed because this is something he's wanted his whole life. He chose this college because he had the best chance and wanted to play for this team, and yada, yada, yada. He's made all of these inroads to get this thing, and now this medical condition stands in his way and has made him really depressed about the whole situation, about his college career, etc. So there's a way in which you can really see the connection, right? That medical piece was really important in terms of what's going on for that person psychologically. Other things might be some diagnosis of a terminal or serious chronic illness, right? Somebody gets diagnosed, God forbid, with cancer or something. like that, right? Obviously, they're going to need treatment in the medical capacity for that, but they are also very likely going to be dealing with what's it like to now be diagnosed with cancer, have to deal with all the treatments and face my mortality, right? All of these different things, again, is a relevant medical condition and may very well be the entire reason that the client shows up. In other cases, it's just a part of what's going on for them. I had a client when I was working in a counseling center a few years ago who was wheelchair bound in college. He was in college at the time, and he had been wheelchair bound since elementary school, I believe, and some of the stuff that we were dealing with was his relationships in college and how being disabled in this way was affecting his ability to create friendships, to create romantic opportunities, right? These type of things. So again, in that way, right, it wasn't he didn't show up because he had this disability, but I might include that, and I think in fact, in that particular case, it would have been something that I would have included later, because it wasn't, again, the reason that person showed up, but later it became relevant, right? It became relevant to the work that we were doing. Hey, this thing about his medical condition is affecting, right, all of these things that we've been working through in terms of social connections and friendships and yada yada. Okay, so again, relevant medical conditions, looking for ways in which they're connected, and again, not necessarily just noting anything that comes up, but noting it if it is influencing the person in any way. And again, it might just be something small like, hey, the person broke their arm, they can still work, they weren't trying out for a sports team, but hey, this has just been kind of tough, and we were working on his roommate relationship, but now that his arm's broken, we're kind of talking about this too. So you might still would put that there. So it's not super restrictive, but just thinking about what's relevant and what's just going on. Similarly, axis 4 is where we're going to write things about what we call relevant life events. So relevant life events, again, similar to this idea of relevant medical conditions, is just really looking into the person's life and thinking about what sorts of changes, what sorts of conditions might be affecting, again, the psychology in particular, the stuff that we're working on with a given client. So if you've got somebody who's just been fired from a job, if you've got somebody who's got a new job, just got married, just broke up, just had a kid, all of these different type of life events, just started college, just graduated, right? All of these things that you can imagine might cause anxiety, might cause depression, might cause worry or fear, or anything that somebody might show up into counseling for. This is the place that you would have noted that small piece. And again, we're really just looking at lines here, right? So this might just be recently divorced, or mother passed away 2 years ago, or just got a new job in a new city, right? All of those different types of things, just giving a brief account of what's going on for the person that seems connected perhaps to their mental status, to their psychology. You're again going to put them here in this 4th axis. And then in this 5th axis, we have what's called a global assessment of functioning. A global assessment of functioning. And this is a score that goes from 0 to 100 that broadly just describes how the client, how the patient is doing overall. So on a scale of 0 to 100, how is that person doing? How severe? How debilitated? How capable is that person when you see them? Now, 0 isn't something that you're going to use a lot. 0 means dead. And I'd always wondered, honestly, in graduate school and even while I was doing some clinical work, I'd always wondered, why is there a 0? Like, when would you ever use a 0? Of course, that's just a naive, younger Dr. Gordon that didn't understand. Of course, you're going to have clients that either die just in the course of your work with them, or unfortunately may die by suicide or die by some other means connected to the work that you were trying to do with them, or maybe it's that medical condition, right? And so it is a number that we use really for sort of a post-mortem. Hey, the judge needs a chart for this guy that recently died by suicide, just to kind of get a sense of where he was, something to give his family, or something to close the record, or whatever it is, right? And so we would use that 0 to indicate, well, this person's dead, but here's what was going on for them. 1 is going to be incredibly, coming up from 0, obviously, is going to be incredibly debilitated. 100 is also a little bit out of the ordinary, just because I'm not even really sure when you use 100. It almost seems like by the description, right, this person's going to be manic, or at least in a really, really excited mood, right? Something really good just happened. They're at their, happiest, and they're working on all cylinders, right? It's just going to be sort of this really exciting, good, happy person. I've never seen 100. So usually really you're working, I will be honest, usually working between 20 and 90 is sort of about where you see scores. At the place that I worked most recent before coming to Missouri, we would kind of use 70 as our kind of cutoff. That is to say, if we had a waiting list and you scored 70 or higher, we would leave you on the waiting list. If you were on the waiting list and you scored 69 or lower, we would put you to the front of the waiting list, if not see you as soon as possible. So this is kind of about where you would say the person's doing okay, but they could use some help. And then as you move up about by 5, by 10, you start getting, around 80 as a person who's, doing pretty good, but maybe is concerned about a few things. 90 is a person who's, functioning capably when their day-to-day life, has relatively regular, worries. Not regular in the sense of they keep recurring, but regular in the sense of, I'm worried about, this performance review, I'm worried about traffic, nothing too wild. And then as you go down from 70, you're starting to think about a person who's having a hard time getting through their day, right? They can't stop worrying, they can't stop crying, they can't approach certain things because it gives them a lot of panic-like symptoms, right? Whatever it is, we're thinking about down here, that this is starting to really distress, it's starting to really do some harm, whereas up here it might be a little bit more okay, so to speak. All that said, these ratings I have found to be really subjective, and not necessarily to the individual, though that is likely to happen, but really more to the idea of to the particular people that you're working with, or a particular organization that you're working with. Like I said, we have this sort of 70 trend, and so I think that kind of set in our brain to think, well, 70's okay, and to sort of work off of that model so that we could kind of inform each other. But then I've seen other folks who, the person's got depression for 2 weeks and then, they're at a 35. And for us in our office at the time, that would have been like, whoa, we need to get this person a lot of help. And then for other people, it's not that bad. So it really is more useful for those internal discussions for a clinician to use, to compare within their own notes, and probably most helpfully, it's really used to track progress of a particular client. Because while I might vary even to the person who's seeing a client in my same office, I'll probably at least be a little bit closer to my own ratings, and certainly closer to my own ratings when considering this particular individual. And so if we see that the person is going from a 35 to a 50 to a 62 or whatever it is, right? These numbers may still be arbitrary in terms of exactly how they're doing, but they do suggest that the person's getting better, right? That the person is coming in and after a few weeks is feeling better, is doing better. So that's really, again, its best use is thinking about how the person's doing over a period of time, more so than you can take this person's 35 and compare it to this person's 70 and say, oh, they're doing this much worse. It's not quite that kind of set in stone. So this is the five-axial model. Again, we don't really use it anymore, but one of the things that the DSM-5 does impress on you, even though it takes out this five-axial model, is that you still should be considering, you still should be notating all five of these things in some way or another. That is to say, if there's no axes and you're just using a blank sheet of paper, you should still note that the person has this particular short-term disorder, that the person has or has no evidence of any type of long-term debilitating chronic disorders. The person is functioning within normal medical parameters, or the person has certain diagnoses that seem to be affecting their mental condition. Similarly here, the person is having reports no problems in terms of life events or no significant life events, or the person has X, Y, and Z that seem to be affecting their A, B, and C. And then overall, how is this person doing session to session or interaction to interaction? You should be tracking that. And the DSM-5 doesn't use the GAF score, but they do use some type of scoring mechanism. I honestly haven't looked too much into it. It's based on the ICD scoring methodology, and it's not that clear. I think there's letters and numbers or this type of thing. So again, this is just one of the ways in which we think about categorizing. I want to talk about just a couple more before we're done with this video. Okay, so the next couple terms that I want to think about are psychosis versus neurosis. Now, I've paired these with this other set of terms, Ego Syntonic and Ego Dystonic, which we will talk about here in a second. The reason I've paired them is because psychosis and neurosis are another one of those things that are really kind of out of use. We really don't use these words in this way anymore. You do, of course, recognize the word psychosis or psychotic, and you obviously, or you probably recognize the word neurosis or at least neurotic, but we don't use them in the way that I'm going to describe them here. Instead, the psychological community at least has kind of transformed these terms, or at least changed what was useful about them into this new set of terms, Ego Syntonic and Ego Dystonic. I say new, but these are probably as old as these are, and we'll talk about that. But these have sort of come back into use, whereas psychosis and neurosis sort of remain kind of archaic ways to describe mental health. So the difference between a psychosis and neurosis, and again, these are really old terms. These are Freudian terms, right? So back in the 1910s, early 1900s, type of terminology. And what we meant when we said a psychosis back in the day was that here's a person who's got a disorder that is so severe. Here's a person who's got a disorder that is so severe that it's taken over their mind such that they can't even tell that they have a disorder. They're not even aware that what's going on for them is in fact not ordinary, is different than who they've been, is different than what everybody else is experiencing, or is just completely off base, right? That this person's so caught up, that this person's so severely struggling, or debilitated by this disorder that they have, that they can't even see their way out of it. They just believe the voices. They just believe the things that they're seeing. They just believe whatever it is that they're feeling, and they don't even know enough, or they're not even kind of connected enough anymore to say, hey, this isn't how I used to feel, or this isn't normal for me, right? They just are in that. So what type of things are those, right? That's obviously psychosis, right? Which we sort of just take that name and applied it to something more specific, but before it meant something more broad. It meant just this broader idea of you were so caught up in the thing that you can't see your way out of the thing. Anymore, we mean psychosis to mean that the person is hallucinating or is deluded in some ways. And so you can see how with a hallucination, for instance, in order to believe a hallucination, you've got to be caught up in it. You've got to not really question it. Now we'll talk about when we get to schizophrenia whether that's true or not, whether people really do or can question their own hallucinations or delusions. But the idea here, the idea of the psychotic or the psychosis, is that the person is caught up and believes it. There's definitely a three-legged dog right here. Definitely. You guys just can't see it, so maybe it's off camera. Anyway, but the idea, right, is I believe that. It's not something I'm worried about. Do you guys, I don't usually see three-legged dogs. Do you guys see it? Right? I'm not aware enough to even be worried about the fact that I'm hallucinating. This is different than the neurosis, which is that you are aware that something has changed about you and you have this dislike of it. You have this distress about it. You have this concern or this fear of it, right? Am I always going to be this nervous when I have to stand up in front of class? I don't like the way this feels, right? That this is something that you're experiencing, right? You're experiencing that anxiety, but you're still able to note that I'm experiencing it. I don't like it, right? You're caught up enough, or you're at least aware of yourself enough to see that before I stepped in front of this class, I was feeling fine, and then I got up here and people are looking and my heart's pounding and I'm sweating and this is strange, right? That you can still have some wherewithal to at least be neurotic enough about your own neuroses. And again, we've kind of taken that word to mean somebody who's worried, somebody who's kind of caught up in the fact that things might go wrong, right? Somebody who's looking for that type of thing. And that's because, again, this sort of original meaning was this was the kind, this was the type of disorder where you could notice it, versus here was the type of disorder where you couldn't. That's an important piece to note, by the way, is that these are categories. This sort of old parlance of neurosis and psychosis are categories. The person has a neurosis. The person has a psychosis, right? And then under that, we might have some particular disorders that we call something called mountain climber's disease, which is like a fear of failure because you've climbed so high. But like mountain climber's neurosis, right? Here's this person who's got a lot of anxiety about failing now that they are at the top of the mountain, now that they've kind of gotten everything that they ever could have wanted. Now they have this anxiety about coming down the mountain, right? And so we would have called that a mountain climber's neurosis because the person is well aware of the fact that not necessarily connected what it is that they're fearful about, but they can at least know that they are experiencing fear that is unusual and distressing to them. They don't necessarily know why, but they just say, I've been feeling really anxious lately. That's still going to be considered categorized neurosis. Again, versus somebody who's hearing voices, just thinks the voices are real, doesn't necessarily believe when other people say that they aren't real, or maybe they do, but then the voices come back and they forget that they were told, right? Whatever it is, they believe in, and that would be a psychosis, right? This person has a psychosis. I'm stressing this because we take that meaning, right? That idea of this is something that I'm used to, this is something that I notice. This is something that has changed versus this is just always how it is. I mean, I can't tell the difference, right? That we have that idea of the psychotic versus the neurotic, but whereas there are categories here, right? Certain things go under neurosis. Depression is a neurosis, right? Anxiety is a neurosis. Mountain climbers disease is a neurosis, right? And I don't think we have these terms yet, but we would say, okay, schizophrenia is a psychosis. I don't know, PTSD is a psychosis, right? That these were just categories. This is important because we can maybe think of a time when PTSD is neurotic, right? When the person is well aware that their fear about, I don't know, the fireworks or whoever's behind that door or whatever it is, they're aware of that fear, right? They're aware that that doesn't feel good. I don't like the way this feels. I wasn't like this before I left, whatever it is. And yet we've categorized it as a psychosis, and so it's just a psychosis. It's sort of that same problem we were having with axis 1 and axis 2, right? Some of these things are slippery and it's tough to really pin them down into categories. Well, luckily, we also have these similar terms of ego syntonic and ego dystonic. These have similar meanings to what we're meaning here by neurosis and psychosis. That is to say, when we say that something is ego syntonic, that means it is in sync with your ego, right? It feels like who you are. It feels like, doesn't everybody see the dog? Right? It doesn't feel like it stands out. It doesn't feel dystonic. It doesn't feel distressing. Because the ego dystonic is the person, this doesn't jive with my ego. I don't like feeling nervous up here when I'm talking. This isn't how I usually feel, or I'm usually not depressed in the ways that I have been these past couple days, right? That it stands out, it's dystonic to one's sense of self, to their ego, whereas this doesn't stand out. This feels like it is in sync, it fits in with a person's sense of their ego. The important difference here is that, again, where these were categories, these are descriptors, right? And so now I'm not forced to say, well, if I have to choose, I guess PTSD is more of a psychosis. Now I can just say that this individual's PTSD, right? Rob's PTSD is syntonic. Right? I can just give this a description, that his PTSD is one in which he doesn't notice that all of the things that he is worried and concerned and checking on are freaking everybody else out, and that's not normal. And his sense of fear isn't necessarily true to life, or isn't everybody else's sense of fear, right? Versus maybe we've got somebody else, right? Here's Mary, and her PTSD is dystonic, right? She's crying a lot, and she doesn't like when these thoughts come back, and she really wishes she could just get back to the way things were, right? The same disorder, same similar, I guess, symptoms, and yet in this case we can think of it as syntonic. The person is just, no, everybody is dangerous. We all should make sure that our doors have 8 locks on them and that we check 4 to 5 times before we go to bed. And don't you leave the house without X, Y, and Z, right? That it doesn't feel like worry to that person. They're expressing that anxiety in some ways, but for them, if you said, do you think you've got, something, do you think there's any problem with what you're doing? Do you think maybe there's something going on with you? No, man, I mean, listen, I'm just being safe. Not like Mary over there is crying about, right? And so they're both dealing with the same thing, and yet we can think about it in a syntonic versus a dystonic way. We couldn't do that with neurosis and psychosis. We couldn't say this is this sometimes and this is this other times. But with ego syntonic and ego dystonic, we can make that differentiation. Syntonic is also going to be things where it really just feels like who the person is. So a lot of those axis 2 disorders, for instance, are going to be things that we would think of as syntonic. Any type of personality disorder, unless it's really, really caused some trouble in that person's life, right? Take the narcissist who just couldn't get a relationship, thinks they're, really hot shit, but they can't get a job because they keep telling their boss off or whatever it is, right? At that point, it might become dystonic. What's wrong with me that I can't get a job? But generally, right? No, I'm just great. It's these guys who can't figure out how awesome I am and won't pay me what I'm worth. So I don't know. I guess I'll try again next week, right? But again, you can see it both ways. But generally, when we think about a personality disorder, things like autism, things like ADHD, things like dyslexia, right? It really just feels like who the person is. The fact that this person has no focus doesn't feel like there's anything wrong. They are used to that aspect of themselves, that they're easily distracted or forgetful or can't sit down for very long. It is who they are, and so they may not quite notice it, or they might like it even. When we think about things like a bipolar disorder, where sometimes the person is depressed, but other times they're manic, some folks enjoy their manic phases. They feel unstoppable. They feel amazing. This is how I really am. This is how I should always feel, right? Again, we would just call that syntonic, right? It is in sync with who that person thinks they are. And then when they're depressed, of course, usually they're going to feel a little bit out of sync. They're going to feel like, hey, this isn't who I am, and that might feel a little bit more dystonic. Though when we talk about depression, we'll talk about some ways in which it can be syntonic as well. Right? You can be depressed and feel like, well. All right, so lastly, and this will be the last set of terms that we do here in this video. It's been a bit of a long one. These will probably all be about this length because this would be a 3-hour class. The video is going to be shorter than that because the lesson I have planned is from previous semesters where I'm making time for questions and making time to make you guys think about some of the stuff that I just write up here. But probably about an hour, hour and a half, you can probably expect these videos to be. So last one is the difference between psychogenic and somatogenic. And here we're thinking about something a bit different than what we've been talking about so far. The idea of psychogenic and somatogenic is really getting at the genesis, that is to say the beginning of a particular mental disorder. That is to say, where does it come from? When we think about something that is somatogenic, for instance, we're thinking about something that originates, genesis, genic, in the body, in the soma. So when we think about something that is somatogenic, we're thinking about some type of psychological disorder that originates in the body. Well, what does that mean? Generally, when we say somatogenic here, we're going to mean brain. I'm sure somebody can think of some examples where that's not the case, but in general, if we're thinking about some type of somatogenic psychological or psychiatric disorder, it's going to be something that's affected the brain in particular. There's going to be some strain or damage or developmental piece to the brain that's changed it in a way that's caused this psychological expression. So this might be things like a traumatic brain injury. Again, this might be something that's developmental. This might be something that's a disease. This might be the result of some type of surgery or a concussion, right? All of these things that are really going to affect the person's brain in this case. Is really going to affect their brain such that this causes depression, or this causes anxiety, or this causes the person to have difficulty focusing, or have difficulty with some type of movement, right? Anything that we're talking about that originates in the brain in particular. I'm stressing this because you're going to get confused when I talk about this one. But anything that affects the brain in particular, brain is not the mind. Anything that affects the brain in particular and causes a psychological result, we're going to think about that as somatogenic. This is compared to something that's psychogenic. That is to say, this originates in the mind. This begins in the mind. Now, this is sometimes tricky for students to get for the reason that sometimes things that are psychogenic can have a physical inciting incident. That is to say, your girlfriend, smacks you across the face, and that makes you anxious, or that makes you depressed for a couple weeks. Now, something physical did happen to you, right? But that physical thing didn't hurt your brain, right? It didn't change your brain to make you depressed. What it did was it upset you, because how could somebody that you've loved and spent a lot of time with do something like that to you, right? That's the upsetting thing. That's the depressing or the anxiety-provoking thing. It's that idea, right? It really is starting in the mind, here's what we mean, right? The idea that this could happen, or the fear that this could mean, right? Those things are starting in the mind such that we would give that a psychogenic label. This is something that began in the mind versus something like a traumatic brain injury that results in, loss of ability to focus that is beginning in the body. Why can't you focus? Well, my brain is swollen. Why are you sad? My girlfriend upset me when she hit me. I think my girlfriend might leave me. I think my girlfriend's an abusive person. Whatever it is, right? It's not affecting the brain. It's making the person think about their life, their world, the people in it, in such a way that's upsetting, that's distressing, that's depressing, right? So we really have to make a differentiation between the things that are starting in the brain. This is important for treatment, of course, right? Somebody comes in and they're depressed, or they're anxious, or they have ADHD symptoms, and I just try to talk therapy them out of it, when it turns out, oh yeah, they forgot to tell me they had a concussion 3 weeks ago, and all of this seemed to start then. Well, me talking them out of it isn't the right course of treatment. What I should be talking to them about is managing the way that they feel, given the fact that this seems to be a somatogenic issue. And of course, refer them to a neurologist or a psychiatrist, perhaps probably a neurologist, to take a look and see if there's anything that physically needs to be treated. In the meantime, yes, it really sucks that you're having this lack of focus due to what's happened to your head, but let's figure out some strategies to make that right. That's different line of work than, okay, it seems like you've got ADHD, let's do some, maybe it's the same, let's figure out some strategies to make sure that you can get by. But at least my line of thinking in terms of, do they also need to go see someone about this physical piece, is opened up. Otherwise, I'm maybe just going to be spinning my tires trying to figure out why they can't get this lesson, or why they're not getting over their anxiety, or whatever it is that would usually be happening at a certain point in time. Okay, so that's the big three here, just in terms of psychosis, neurosis, syntonic, dystonic, and psychogenic, and somatogenic. Really, again, just beginning to think about ways in which we can slice up this idea of mental disorders. Really beginning to think about how they show up, and in some ways where they come from, right? And this is just, again, this sort of simple division of somatogenic, psychogenic, and then thinking about, does the person feel like it's connected to who they are? Do they feel like this is something that showed up and now I want to get rid of it? And of course, also, we started by talking about the five-axial model and how that can be helpful to conceptualizing the full battery of what's maybe going on for a particular individual when they come in or leave, or in the midst of treatment. Okay, so next time, one of the things that we're going to start talking about are what I call psychological determinants. And this is just to say, now we're thinking about here sort of the categorization, but the next thing I want to think about is, how do these things come to be? Where do mental disorders come from? And there's a lot of discussion on this, and there's I wouldn't call it controversy, but there's a lot of disputes in terms of, is this more of a psychological piece? Is this more of a medical piece? And so we're going to cover both of those things. We're going to start by covering the psychological piece. I will say now, I may change my mind on this, but what I may do is just link you, or even just put it in the playlist, the lecture that I've given to my general psychology class, which is the exact same lecture that I would be giving to you, just to kind of catch us back up on the ego, superego dynamic. Usually I would just give you that lecture fresh, but I think I'm just going to link you to that video for this week, and then maybe even next week's video, depending on how long it goes for. And then after that, what we would do is pick up, and this would be me in here, not that maybe you know the difference, I thought I'll have a mask on, as I will in that video. But we pick back up in here and think about the medical piece of those determinants, right? So what's maybe going on in the brain in terms of neurotransmitters, and also thinking about some ways in which treatment modalities play off of that sense of which neurotransmitters seem to be connected to which psychological disorders. All right, email again if you have any questions. This has just been the second video, so if you've watched 2 of these, you are caught up. You'll see the one for next week posted probably pretty soon, especially if I'm going to share that link. And then I'll see you again here in a couple of weeks, where again we'll start talking about the medical piece of these psychological determinants. Take care.